Hello and welcome to our program In the Know, key abstracts from the American Society of Hematology 2021 annual meeting in acute lymphoblastic leukemia. This program is supported by an independent medical education grant from Jazz Pharmaceuticals. Before we start, please take a moment to let us know who you are and answer the pre-polls in the tweets below. Tweets also include details regarding how to obtain your free CME credit. Be sure to watch our handles for additional ALL CME programming, as this program is a 6-part series, and follow @Bonum CE for more CME certified programs on Twitter. I'm Dr. Ryan Cassaday, Associate Professor of Medicine at the University of Washington School of Medicine and Fred Hutchinson Cancer Research Center in Seattle, Washington. And I'm joined today by my colleague, Dr. Luke Maese.
I'm Luke Maese, Associate Professor of Pediatrics here at the University of Utah School of Medicine, Huntsman Cancer Institute, and Primary Children's Hospital in Salt Lake City, Utah.
Here you will see our faculty disclosures for your review. Upon completion of this educational activity, participants should be able to first compare asparaginase Erwinia chrysanthemi, hereafter referred to as recombinant Erwinia asparaginase, with asparaginase Erwinia chrysanthemi ERW, hereafter referred to as native Erwinia asparaginase, based on efficacy, toxicity, manufacturing, dosing, and administration, and then to describe the dosing, efficacy, and safety of recombinant Erwinia asparaginase. And now I'll hand it over to Luke to take us through some of the data.
Thanks, Ryan. So first we'll review, everyone, this abstract, the initial results from a phase 2-3 study of recombinant Erwinia asparaginase in patients with acute lymphoblastic leukemia or lymphoblastic lymphoma who are allergic or hypersensitive to E. coli-derived asparaginase. This abstract, again, was reported at the ASH annual meeting last year. So as a brief background, asparaginase is associated with unique toxicities, most of which are non-fatal and manageable, as well as reversible. Due to a lack of clear guidelines, many clinicians truncate asparaginase therapy following such toxicities, which sometimes isn't necessary depending on the patient and the situation. Toxicities that are associated with PEG asparagase include anaphylaxis or allergic hypersensitivity reactions, but also other reactions including hyperglycemia, high triglycerides, elevated bilirubin, pancreatitis, and thrombosis. Allergic or hypersensitivity reactions require careful assessment of symptoms and serum asparaginase activity levels to determine if it is an infusion reaction that can be managed with pre-medication or a hypersensitivity reaction that is associated with reduced asparaginase activity, and the patient is best managed with a change in asparaginase products. So clinically available L-asparaginase is derived from two sources, E. coli or Erwinia chrysanthemi. Patients with an allergic reaction to E. coli asparaginase can be successfully managed with Erwinia chrysanthemi-derived products. However, a change in product is not helpful in managing other types of asparaginase toxicities. Most of the non-allergic toxicities can be managed with supportive care and holding therapy until toxicities have improved. Patients with severe pancreatitis and cavernous sinus venous thrombosis should permanently discontinue asparaginase therapy. The figure on the left displays a comparison of patients treated on the AYA protocol CAL-BG 10403 and patients treated on the Children's Oncology Group or COG protocol 0232. So these protocols in essence were very similar, and the figure provides some insight into the comparisons between grade 3 and grade 4 allergic reactions across these two patient populations. So as you can see, the incidence of reactions was greater in the post-remission phase and greater in the 0232 protocol, which is consistent with previously demonstrated data that has shown increased incidence of hypersensitivity on repeat exposure and in younger patients. Additionally, you can see the relative percentages of patients who completed all their asparaginase therapy within both protocols. And in the 0232 data, this is broken down by age, with older patients being at greater risk for discontinuation of therapy. Piggybacking then on this information, the curve on the right comes from a seminal publication from Sumit Gupta and colleagues from the COG-ALL committee, which included a multivariable analysis on the impact of omitting PEG asparaginase doses on outcome in childhood acute lymphoblastic leukemia for both patients enrolled in protocols AALL-0331 and AALL-0232. Now, the Kaplan-Meier curve displays disease-free survival on the y-axis and years on the x-axis. In the dotted red lines, you can see that this group of patients who did not receive their prescribed asparaginase courses had inferior disease-free survival when compared to the other two curves, both of which overlap, one of which is patients who were able to complete all their prescribed PEG asparaginase doses, and the other curve, which separated out those patients who completed their asparaginase courses with Erwinia substitution due to hypersensitivity reaction. This analysis did show statistical significance. So in the setting of hypersensitivity reaction necessitating a switch to a non-E. coli-derived product, the main options include two types of Erwinia chrysanthemi products. Asparaginase Erwinia chrysanthemi, also known as Erwinase, which was the only Erwinase-based product available up until June of 2021, when asparaginase Erwinia chrysanthemi, Arwin, also known as recombinant Erwinia, was FDA approved. So recurrent intermittent drug shortages of Erwinia asparaginase have affected patients with ALL worldwide since 2016 due to manufacturing complexity, resulting in disruption in the ability to make the product available. Importantly, when replacing peg asparagase, 6 doses of Erwinia chrysanthemi are typically given. With asparaginase Erwinia chrysanthemi, this is done on a Monday, Wednesday, Friday, and can be administered IV or IM. Recombinant Erwinia is derived from a novel Pseudomonas fluorescens expression platform to produce an enzyme that is similar in makeup to Erwinase. There is a significant difference in the number of fermentations used per batch of recombinant Erwinia versus Erwinase, leading to increased production efficiency of recombinant Erwinia relative to Erwinase itself. There is a low risk of having component-related particles with recombinant Erwinia due to the use of low particulate filling components in manufacturing process, an issue which has contributed to the drug shortages realized in the past. For recombinant Erwinia, the FDA-approved dose is 25 milligrams per meter squared, given at an every 48-hour schedule. So here we have the introduction to the phase 2/3 study that was conducted with the Children's Oncology Group in Jazz Pharmaceuticals. This included patients who had a hypersensitivity reaction to an E. coli-derived product. They, of course, needed to have remaining doses of peg asparaginase in their treatment plan. It was divided into 2 parts. Part A looked at the intramuscular route of administration, and Part B looked at the intravenous route of administration. For today, we'll be focusing on Part A. Key inclusion and exclusion criteria are listed below, some of which we've already mentioned. Some key exclusion criteria, which we haven't discussed yet: any patient who had relapsed disease was not eligible, and then any patient with a asparaginase-associated toxicity, which included pancreatitis, hemorrhage, or thrombosis, were not eligible as well. The endpoints, importantly, are noted at the bottom. So the primary endpoint revolved around the proportion of patients who achieved a serum asparaginase activity level of greater than or equal to 0.1 with their last 72-hour level that was checked in their first treatment course. We also looked closely at safety and tolerability. A secondary endpoint of note was the last 48-hour NSA level, and this needed to meet the threshold of greater than or equal to 0.1. This study enrolled children and young adults ages 1 to 25, as you see here, broken down by cohorts, 25 milligrams per meter squared on Monday, Wednesday, Friday. Then the middle cohort, 37.5 milligrams per meter squared on Monday, Wednesday, Friday. And then you have 25 milligrams per meter squared on Monday, Wednesday, and 50 milligrams per meter squared on Friday. Most patients who enrolled had B-cell acute lymphoblastic leukemia and met criteria for enrollment due to a grade 3 or greater allergic reaction to an E. coli-derived product. As of the data cutoff reported in the ASH abstract, 33 patients were enrolled in cohort 1A, 53 were enrolled in cohort 1B, and 51 were enrolled in cohort 1C. The adverse effect profile shows that the majority of patients did tolerate recombinant Erwinia without significant side effects. The rate of discontinuation is listed by cohort and reasoning at 9%, 6%, and 2%, as you see there in the table on the left. This percentage of patients discontinued treatment due to an adverse event, while allergic reactions to recombinant Erwinia were observed in up to 26% of patients. Many of these were rashes, and these allergic reactions only led to discontinuation of asparaginase therapy in 6% of patients in cohort 1A and no patients in cohort 1B or 1C as the data cutoff for this abstract. On the right, all grades of elevated AST, ALT, and bilirubin are noted by cohort, along with thrombosis, pancreatitis, and allergic reaction. The primary efficacy endpoint of the trial, as we reviewed, was evaluated by the proportion of patients with the last 72-hour who achieved a serum asparaginase activity level of greater than or equal to 0.1, while the key secondary endpoint looked at the last 48-hour greater than or equal to 0.1. So for the dosing regimen of 25 milligrams per meter squared IV Monday, Wednesday, Friday, SA levels were greater than or equal to 0.1, in over 90% of patients at a 48-hour level, but only in 2/3 of patients at a 72-hour level. Thus, as you can see here, the FDA approval in adult and pediatric patients 1 month or older who have developed hypersensitivity to an E. coli-derived asparaginase is for 25 milligrams per meter squared, given intramuscularly every 48 hours. Patients receiving a dosing regimen of 25 milligrams per meter squared on Monday, Wednesday, and 50 milligrams per meter squared on Friday, you can see in the bar graph, achieved SA levels greater than or equal to 0.1 in over 90% of patients at both the 48-hour and 72-hour time points. So in conclusion, the FDA-approved dose, again, of asparaginase erwinia chrysanthemi or recombinant erwinia is slightly different than how we studied it. And this is at a 25 milligrams per meter squared intramuscularly given every 48 hours. This approval is based on the 48-hour serum asparaginase activity levels that were displayed. We do know that over 90% of patients in each cohort were able to continue with asparaginase therapy, indicating that the toxicity is manageable in this cohort of patients.
Great. Thanks a lot, Luke, for that really nice comprehensive overview. So a couple comments and questions, if I may. So as you concluded there, the FDA approved dose of recombinant Erwinia asparaginase of 25 milligrams per meter squared IM every 48 hours was different than what was actually studied, where it was more of a Monday, Wednesday, Friday schedule. So I'm curious, how are you managing this? How are you sort of rationalizing that difference? Are you bridging patients, or I'm sorry, are you bringing patients in over the weekend to maintain that every 48-hour schedule? Is your clinic open every day of the week, or are you doing that off-label approach with the higher dose on Fridays?
Great question. This is one of those questions that frequently comes up, Ryan, and I think it can be a different answer depending on the institution's resources. And we've had these discussions in the past, and in terms of capability of your particular institution, your nursing staff, your pharmacy staff, your pharmacy in the hospital. So initially, when it was approved, before we had this ASH data available, we were bringing patients on the weekends. We are fortunate to have that resource here where we can do this every 48 hours. Families were amenable to this. We didn't really have many issues, again, because there was nothing else available for these patients, and they're grateful to have the medication. Now, with the 50 milligrams per meter squared data becoming a bit more mature, having this report from ASH, we are more comfortable with using this 25-25-50 dosing and have started to utilize it for more patients. Again, I still think it comes on a patient-by-patient basis, and we do have those discussions when they come up.
Sure, that sounds good. I'm curious, at your center, have you been able to get access to the vanishingly small supply of the native Erwinia product recently, or have you pretty much made the transition to the new recombinant product?
Yeah, right now, unfortunately, we haven't had access to Erwinaze, the traditional product, for some time now. I can't remember when is the last time we had it available. I think when we started, when this trial started enrolling patients, we did still have some, but probably mid-trial, end of the trial, we didn't have any. And so in the patients who weren't enrolled on the trial, we didn't really have many options for them. But now, since the FDA approval, we do. And so, yeah, we have pretty much exclusively moved to recombinant Erwinia at this point.
Yeah, we're the same at my center too. I can't even remember the last time we had the native product available. And then lastly, kind of getting more to the data that you presented, I'm curious, I didn't think that it was mentioned, but do we know anything about how allergic reactions to the recombinant product correlate with asparaginase activity levels? I saw that there were still some allergic reactions to this newer product. Are they also associated with reduced activity levels? Do we know?
Yeah, great question. I think we know that there's going to be hypersensitivity, right, with a product that's derived from a foreign protein, and not surprisingly, we saw some of that. I think our primary endpoint and secondary endpoint revolved around these activity assay levels, and that's what we have available now. I don't have any insight here at this point into the correlation, but certainly something that's an important question to ask, and that will be upcoming in some of these secondary analyses that we're doing across the board as we get more information. And again, I'll note, this was an early report where we want to get this data out there as soon as we can responsibly, but patients are still getting the drug, and we're going to be getting more and more information and updating it as we get that.
Great. That's good to know. Something to look forward to. All right. So with that, thank you so much for joining us today. Please make sure to claim your CME credits by completing the post-test and evaluation form at the link on your screen, and make sure to follow Bonum CE on Twitter to stay tuned for more ALL content. So on behalf of my colleague, Dr. Luke Maese, thanks a lot for participating and watching.